Welcome back to the deep dive. Today, we're taking a really interesting plunge into some pretty complex veterinary material.
We are indeed. We've got excerpts here from a detailed text, and we're focusing on a specific and sometimes, well, quite sneaky condition in dogs.
Canine pneumocystosis.
That's the one.
Yeah.
And our mission, really, for this deep dive is to get a clear picture, what causes it, which dogs are most vulnerable, and why.
And then really unpack the diagnostic process, which sounds pretty fascinating based on this material, and of course how it's treated.
Exactly, because as you said, this isn't just, a simple cough or bug. The source really highlights how it's tied to underlying issues.
And figuring it out involves some intricate steps. So yeah, let's dig in.
Right.
So first things first, the basics. What exactly is the culprit, this Pneumocystis carinii?
Right. So the source describes it as an atypical fungal organism, but also, interestingly, a saprophyte of low virulence.
Okay, that sounds a little contradictory. A fungus, but low virulence.
It does, doesn't it? And that's kind of key. While it's classified with fungi, based on its genetics and structure, it doesn't really act like many disease-causing fungi we typically think about. A saprophyte, well, it usually lives on dead or decaying stuff.
But this one lives in the lungs.
Precisely. Its main habitat is the lung tissue itself, and it infects, well, virtually all mammals worldwide, often without causing any problems at all.
So wait, most dogs might just have it hanging around and their immune system just deals with it.
That's exactly right. Subclinical infections, meaning the organism's there, but the dog isn't sick, seem to be really common.
Okay.
The big shift happens when we talk about clinical infections, where the dog actually gets sick. And in dogs, that is very, very strongly linked with immunodeficiency.
A weak immune system being the key.
Yes. And what's interesting, the source specifically points out that common cat viruses like FIV and FEL-LV, they don't seem to predispose cats to getting sick from this.
Huh. So it's not really reported as a clinical problem in cats, according to this text?
Apparently not. A real species difference there.
Fascinating. Okay, so if a weak immune system is the trigger in dogs, who does that mainly affect? You mentioned young dogs.
Yes, young dogs are the primary age group. But the breed thing is really crucial here.
Ah, right. The source names specific breeds.
Miniature Dachshunds and Cavalier King Charles Spaniels. They're highlighted as being particularly vulnerable.
And why those two? Is it something specific about their immune systems?
It seems so. The text links it to congenital immunodeficiency, basically. They're born with it.
Okay.
Miniature Dachshunds are described as having, well, pretty severe immunosuppression, specifically a deficiency in IgA, IgG, and IgM.
Okay, quick pause. IgA, IgG, IgM, those are types of...
Antibodies. Think of them as different types of soldiers in the immune system's army.
Got it. So a lack of those soldiers leaves them vulnerable.
Exactly. And Cavalier King Charles Spaniels, they also have immunoglobulin deficiency, so low antibodies again, but also decreased function of their lymphocytes.
Lymphocytes, another type of immune cell.
Right, another key player. So these built-in weaknesses mean an organism that a healthy dog might not even notice can cause really serious problems in these breeds.
That makes a lot of sense. And how does it typically spread? From dog to dog?
The main way seems to be airborne droplet transmission.
Like coughing or sneezing.
Exactly. Tiny moisture particles carrying the organism through the air. There's also mention of possible transmission in newborns, maybe through aspirating contaminated amniotic fluid during birth.
Okay. Are there other risk factors besides those specific breeds or being young?
Definitely. Any other underlying reason for immunodeficiency or even just pre-existing lung disease can increase the risk.
Makes sense.
And the source also notes a higher frequency of clinical disease in dogs that are already infected with canine distemper.
Ah, because distemper itself suppresses the immune system.
Precisely. It adds another layer of vulnerability.
Okay, so we've got the organism, where it lives, who's most at risk. What does it actually look like when a dog gets sick? What are the signs vets look for?
Well, the onset is usually quite insidious. It creeps up over weeks, sometimes even months.
Not sudden, then.
Not typically. The two main things you'll see are respiratory difficulty, trouble breathing, and weight loss.
Breathing trouble makes sense if it's in the lungs. But the source specifically mentioned difficulty breathing without a fever. That seems unusual for pneumonia.
It is, and that's a really key diagnostic clue for the vet. So many lung infections cause a fever.
Right.
So seeing that dyspnea, that difficult breathing without the high temperature, can really help a vet start narrowing down the possibilities.
Okay. What else might you see?
Other signs can include exercise intolerance. The dog just doesn't want to run or play like usual. Coughing can happen too. and sometimes less specific things like vomiting or diarrhea.
And there was a mention of a really severe sign in late stages, cachexia.
Yes, cachexia. That's basically severe muscle wasting and weight loss.
Mm.
It indicates a chronic, really debilitating disease process that's been going on for a while.
So you'd see a dog getting thinner and thinner, finding it hard to breathe, maybe not wanting to move much, and possibly no fever.
That's a pretty typical picture, unfortunately.
Okay, this leads us straight into the diagnosis, which, as you hinted and the source makes clear, sounds like it's anything but straightforward.
Absolutely not, because those signs we just talked about, they aren't unique to this condition at all.
So the vet has a long list of other possibilities to rule out.
Exactly. This is when they start thinking about the differential diagnosis. What else could it be?
And that list sounds pretty extensive.
What is? The source gives examples like various inflammatory lung diseases, chronic pulmonary fibrosis, eosinophilic bronchopneumopathy, fancy names for lung inflammation.
Okay.
Then there are tons of other infectious things, other systemic fungal infections, toxoplasmosis, parasites like lungworm, bacterial pneumonia, viral infections.
Wow.
Plus, you have to consider heart problems like congestive heart failure or blood clots in the lungs, thromboemboli. Even things like a foreign body stuck somewhere, or tumors, or non-cardiogenic pulmonary edema, which is fluid in the lungs not caused by the heart.
So it's a huge range. Where does a vet even start when faced with those non-specific signs, routine blood tests?
Yeah, initial tests like a CBC complete blood count, a biochemistry panel, urinalysis. They're standard procedure, but the changes they show are usually pretty nonspecific for pneumocystosis itself.
Meaning they show something is wrong, but not what.
Exactly. You might see general signs of inflammation, like leukocytosis, high white blood cells with neutrophilia, maybe even immature neutrophils, what we call a left shift. Eosinophilia and monocytosis are also mentioned sometimes.
Are there any clues on those routine tests that might point slightly more towards this, even if not definitive?
Well, there can be a few hints. Because the dogs often have chronic low oxygen, you might see something called erythrocytosis, an increase in red blood cells. It's the body trying to compensate, trying to carry more oxygen.
Ah, okay.
And interestingly, platelet counts can vary by breed, according to the source. Low platelets, thrombocytopenia, might be seen in Cavaliers.
But high platelets in dachshunds?
Potentially, yes, thrombocytosis. And given the underlying immune issue, you might also find hypoglobulinemia.
Low levels of those antibodies we talked about earlier.
Right, IgA, IgG, IgM. So finding that could add a piece to the puzzle. But again, none of these scream pneumocystis. They just add context.
Okay, so the routine stuff is a bit vague. Where do you go for tests that give more direct insight into how the lungs are actually functioning?
This is where arterial blood gas analysis becomes really useful. It directly measures oxygen and carbon dioxide levels in the arterial blood.
And what does that typically show in these cases?
Our source points to findings like hypoxemia, that's low oxygen in the blood, hypocapnia, low carbon dioxide, alkalosis, and importantly, an increased alveolar arterial oxygen tension difference.
Okay, that last one sounds technical. Alveolar arterial oxygen tension difference. In simple terms.
Think of it as a measure of how efficiently oxygen is getting from the air sacs in the lungs, the alveoli into the bloodstream, the arteries.
Right.
A big difference means there's a barrier. The oxygen isn't crossing over properly. It strongly suggests a problem within the lung tissue itself, messing up that gas exchange.
That makes sense. A direct measure of lung impairment.
Exactly. And another test mentioned is actually quantifying those immunoglobulin fractions we discussed, IgA, IgG, IgM. Measuring them can confirm that hypogammaglobulinemia,
Low antibody levels.
which really strengthens the suspicion of an underlying immune problem driving the whole thing. The source also mentions things like antibody tests or PCR on fluids or tissues looking for the organism's DNA or proteins can sometimes give clues earlier, too.
What about looking at the lungs? Imaging. Chest x-rays.
Essential, yes. Thoracic radiography is key to see what the lungs look like structurally, how widespread the changes are. But, and this is a big but, the source emphasizes the changes you see are not specific for P. carini.
Meaning other diseases can look similar on an x-ray?
Exactly. You'll typically see diffuse patterns spread throughout the lungs, often described as a miliary interstitial to alveolar pattern, sometimes with parabronchial opacification.
Okay, let's break that down. Miliary interstitial to alveolar.
Think of it as a mix of tiny dots scattered everywhere, like millet seeds, that's the miliary part. plus thickening of the tissue between the air sacs and the interstitial part, and sometimes those air sacs themselves filling up the alveolar part. So it's kind of a hazy, patchy look rather than one solid area of pneumonia.
And parabronchial opacification.
That just means the tissues around the airways look denser or whiter on the X-ray, like the airways are outlined?
Got it. So a diffuse, hazy pattern. Are certain parts of the lungs usually worse?
The source notes the middle lung lobes often seem more severely affected compared to the front and bottom lobes.
And can X-rays show complications from the disease?
Oh, yes. Because the lung disease can be severe and chronic, you might see things like cavitary lesions, basically, holes forming in the lung tissue, or even spontaneous pneumothorax.
Which is a collapsed lung.
Well, air leaking out of the lung into the chest cavity, which can cause the lung to collapse, yeah? And because the diseased lungs make it harder for the heart to pump blood through them.
It puts a strain on the heart.
Exactly. Especially the right side of the heart, which pumps blood to the lungs. So you might see signs of this on the X-ray, like right-sided heart enlargement, the trachea being pushed aside, or enlarged pulmonary arteries.
And this can lead to heart failure.
It can eventually lead to something called cor pulmonale. That's specifically right-sided heart failure caused by underlying lung disease, increasing the resistance the heart has to pump against.
Wow. So the X-rays show the damage and the consequences, but still don't definitively identify the pneumocystis organism itself.
Precisely. Imaging tells you how bad the lungs are, but not why.
Okay, so non-specific signs, non-specific routine labs, non-specific X-rays. This feels like detective work. How do you finally nail the diagnosis? What's the definitive step?
This is really the crucial part. The definitive diagnosis comes down to directly visualizing the P. carinii organism itself. You have to find it.
Find it where?
In samples collected from the respiratory tract. So fluids, maybe sputum if the dog is coughing stuff up, or ideally tissue biopsy specimens.
And how do you get those samples reliably from deep down?
The source lists a few reliable methods: transtracheal aspiration or TTA.
Sticking a needle or tube into the windpipe?
Essentially, yes, to collect fluid. Then there's bronchoalveolar lavage, or BAL.
What's ball?
That's done using a bronchoscope, a camera down the airway. You gently flush a small amount of sterile saline into a section of the lung and then suction it back out, collecting cells and fluid.
Okay.
And you can also use transbronchoscopic or endobronchial brushing, using a tiny brush through the scope to scrape cells directly from the airway lining.
So ways to get samples from where the organism is likely living.
Right. These get you much closer to the source than just, say, a swab from the throat.
Once you have that fluid or those cells, how do you look for the organism? Is just looking at the cells under a microscope cytology enough?
Cytology is often done first. It's less invasive, but the source is quite clear. It's not as reliable or definitive as histopathology.
Histopathology being...
Looking at the structure of a processed tissue sample, not just loose cells.
So a lung biopsy gives the best chance of seeing it in context.
For histopathology, yes, a biopsy is considered definitive. But as you can imagine, taking a piece of lung tissue, it's invasive.
Risks involved.
Absolutely. Potential complications mentioned are hemorrhage, bleeding, or causing a pneumothorax, that collapsed lung issue.
Okay, so biopsy is definitive but risky. Is there another way the source highlights?
Yes, and this sounds incredibly useful. Immunohistochemical kits, IHC.
How do those work?
They use specially designed antibodies that stick only to proteins found on the P. carinii organism. So the antibodies stick and create a signal you know the organism is there.
And that's considered very reliable.
The source describes a positive result as specific and highly diagnostic. And the great thing is, you can use these kits on different sample types, even those cytologic samples from BAL or brushing, or on preserved tissue samples.
That seems like a major advantage. Less invasive sampling might still give a definitive answer.
Potentially, yes.
Oh, well.
But there's a really important caveat mentioned.
Oh.
The source notes there's evidence of host species-specific antigenic variation.
Meaning
Meaning the proteins on the surface of the organism might be slightly different depending on whether it's infecting a dog or a human or a rat.
Ah, so the test kit, which uses antibodies.
Exactly. If the kit's antibodies were primarily designed based on, say, the human form of the organism, they might not bind as well or at all to the specific variation found in dogs.
Leading to a false negative, even if the dog has the infection.
It's a possibility that needs to be considered. It adds a layer of complexity even to these advanced tests.
Wow, okay. So even the specific tests require careful interpretation. Now, if you do get a tissue sample, maybe from a biopsy or, sadly, postmortem, What does the lung actually look like, grossly and microscopically?
Grossly, meaning just looking at the whole lung, the source describes them as firm, consolidated, so dense and heavy, not light and airy like healthy lungs, often pale brown or gray.
And they don't collapse.
Right. Unlike healthy lungs that deflate when the chest is open, these tend to hold their shape. Fluid doesn't easily squeeze out. You might also see a little bit of fluid around the lungs in the pleural space.
And under the microscope, what's the telltale sign?
The microscopic hallmark that pathologists look for is that the alveolar spaces, the tiny air sacs, are filled with this amorphous, foamy, eosinophilic material.
Phony material?
Yeah, and it often has a distinctive honeycombed appearance. Seeing that foamy, pinkish stuff filling the air sacs is a huge clue.
And can you see the organism itself in there?
Sometimes, yes. Within that foamy material, you might be able to identify the different life stages, the trophozoites and the cysts. You might also see enlarged lymph nodes nearby, and that right-sided heart enlargement we discussed.
Now, you mentioned earlier that seeing the organism isn't easy with standard stains.
Absolutely critical point. The standard stain used in pathology, H&E, hematoxylin, and eosin,
Yeah.
it only weakly shows the organism's internal bits. It doesn't really make the organism itself stand out clearly.
So you need special stains.
Yes. To really visualize the walls of the cysts, which are a key diagnostic feature, you need specific stains. The source lists methenamine, silver, toluidine blue, gram stain, and periodic acid Schiff, or PAS.
So this confirms why it's not found on routine tests. You need specialized lab work just to see it properly.
Exactly. It requires specific techniques and expertise. It's not something you'd just stumble upon with basic staining.
Okay, so it's definitely a challenging diagnosis, often needing these specialized procedures. Once you have that confirmed diagnosis of pneumocystosis, how do you go about treating it?
Well, treatment usually starts with inpatient supportive care, especially if the dog is really struggling to breathe, has significant pneumonia.
What does that involve?
Pretty standard supportive measures for pneumonia. Oxygen therapy is key, nebulization creating a mist the dog breathes in, and coupage, gently tapping on the chest wall to help loosen secretions in the airways. Bronchodilators might be used to help open up the airways, and intravenous fluids if the dog is dehydrated or can't drink enough.
In general management for these often immunocompromised dogs.
Super important. You absolutely want to minimize their exposure to any other potential infections. And critically, if the dog happens to be on any immunosuppressant drugs for some other reason.
Like steroids for allergies.
For example, yes. The source advises discontinuing those agents if at all possible, because you don't want to further weaken the immune system.
Right. I saw an interesting note about glucocorticoids, like steroids, but in humans.
Yes, that was an interesting aside in the source. It mentioned that in humans with this infection, using anti-inflammatory doses of glucocorticoids actually seemed to improve lung function and survival rates.
But it didn't explicitly say that's standard for dogs with pneumocystosis.
Not explicitly for this condition in dogs, no. It was presented more as a finding from human medicine, but it's an interesting point. And of course, rest is vital. Strict cage rest or very limited activity for a dog that's struggling.
Okay, that's the supportive side. What about medications to actually kill the pneumocystis organism itself?
The preferred therapy, according to this text, is trimethoprim sulfonamides, often abbreviated as TMS.
That's an antibiotic combination, right?
Yes, a common one. They provide dose options and recommend treatment typically for about 3 weeks initially. There's also a note that, again in humans, giving it intravenously seemed more effective than orally.
Are there other drug choices if TMS isn't suitable or doesn't work?
Yes, the source lists alternatives. Pentamidine isethionate is one, usually given by injection daily for 3 weeks. Another is atovaquone, which is given orally, also daily, for 3 weeks.
How does atovaquone compare?
The text notes it's perhaps not quite as effective as TMS, but it's considered less toxic.
Okay. Any other drug combinations mentioned?
Yes, they list combinations like clindamycin and primaquine, or dapsone and trimethoprim as other possibilities.
And what about newer or potential future treatments?
The source briefly mentions caspofungin, which is an antifungal drug, but explicitly states there are no reported veterinary cases using it for this yet. And another drug called trimetrixate is mentioned as a potential option.
Interesting point here. It says you can start treatment before getting the final diagnosis.
Yes, that's a useful clinical tip. Treatment can apparently be started 24 to 48 hours before you collect the definitive samples, like from a BAL, without necessarily masking the organism and preventing diagnosis.
That's good. Allows you to start helping the dog sooner if you have a strong suspicion. What about side effects from these main drugs?
They definitely need monitoring. With TMS, trimethoprim sulfonamides, if side effects pop up, or if you anticipate needing long-term therapy, supplementing with folic acid is recommended.
Why folic acid?
TMS can interfere with folate metabolism, so supplementing helps counteract that.
Okay. And pentamidine, you mentioned atovaquone was less toxic. Does pentamidine have significant risks?
It does. The source lists quite a few potential complications: kidney problems, liver issues, hypoglycemia, low blood sugar, hypotension, low blood pressure, low calcium, skin reactions like hives, and various blood disorders.
Wow, yeah, that sounds like a drug you need to use very carefully with close monitoring.
Absolutely. Which leads into follow-up. How long does treatment usually last, and what monitoring is needed?
You said 3 weeks initially.
That's the initial course often mentioned, but the source explicitly notes that treatment may require an extended course, potentially lasting months, not just weeks.
Months, okay. And how do you track progress?
You need to monitor the dog closely. Their clinical signs, breathing effort, energy levels, rate, vital signs. And repeating chest x-rays is crucial to see if those hazy lung patterns are actually improving.
And specific monitoring for that riskier drug, pentamidine.
Yes, because of the kidney and blood sugar risks, the recommendation is to check BUN, blood urea nitrogen, a kidney value, and glucose levels daily while the dog is receiving pentamidine.
Okay, so quite intensive monitoring needed there. All right, let's try to wrap this up. This deep dive into canine pneumocystosis. What are the big takeaways?
Well, first, it's caused by this atypical fungus-like organism, Pneumocystis carinii, which is usually harmless.
Right, it only really causes disease in dogs with weakened immune systems.
Exactly, especially those specific predisposed breeds like miniature dachshunds and cavaliers who have those congenital immunodeficiencies.
And the symptoms, breathing difficulty, weight loss, often no fever, they're very nonspecific.
Which makes the diagnosis really challenging. It could look like so many other serious lung conditions.
So vets have to go through this whole process. Routine tests and x-rays give clues, but they aren't definitive.
No. You ultimately need to get samples from deep in the lungs using things like BAL or brushing.
And then use specialized lab techniques like specific stains or immunohistochemistry to actually find the organism or its components. Regular methods just won't cut it.
Precisely. It requires that extra level of investigation.
And treatment involves supportive care for the pneumonia, plus specific medications like TMS, potentially for months, all while managing the dog's fragile state and monitoring for drug side effects.
That's a good summary. It's a complex condition from start to finish.
You know, really digging into this one condition, especially that complicated diagnostic journey, it really underscores the level of sophistication involved in veterinary medicine today.
It really does. It's far beyond just listening to a chest and prescribing antibiotics.
Yeah. What strikes me is how this organism, Pneumocystis, is so linked to these often subtle underlying immune issues, particularly in certain breeds, and the path to figuring it out, it's not straightforward at all.
No, when those initial signs could be, a dozen different things, and the real answer requires going deep, using special stains, maybe advanced antibody tests with their own potential pitfalls.
It really drives home how vital a detailed patient history is, knowing about breed predispositions and having access to and knowing when to use these more advanced diagnostic tools. It makes you think, doesn't it?
About what specifically?
Well, considering how complex this one diagnosis can be, hidden beneath relatively common signs, what does this tell us about the layers of investigation potentially needed to truly get to the root cause of illness in our pets, especially when things aren't immediately obvious? How much might be missed if we only scratch the surface?
That's a really important thought. It highlights the need for persistence and thoroughness in veterinary diagnostics, something definitely worth pondering.